Patient called EHS this morning as his family doctor informed him that his INR was high. Upon assessment, it turns out the patient has a 4-day history of bloody tarry stool, as well as a 4-day history of nausea, dizziness, and feeling generally unwell, as well as a burning feeling in his epigastric region.
Patient is speaking in full and complete sentences. No stridor, no hoarseness, or gurgling is noted. Patient was vomiting upon arrival, therefore section brought to the bedside. Vomiting is now dissipated. Mouth is inspected for any foreign bodies or emesis that could impede his airway, but nothing is found. Patient denies any cervical tenderness. C-spine precautions not instituted. Patient's chest is rising and falling symmetrically. Patient is breathing at 22 breaths per minute. No accessory muscle use or sternal tug is noted. Upon auscultation, patient has decreased air entry to the left lobe, but no abnormal lung sounds. Patient's complaining of purulent sputum. Patient noticeably pale. 5 liters nasal prongs applied as he's showing indicators for supplemental oxygen. Using the ED handshake, a +3 radial pulse is noted, which is strong yet irregular. Patient's skin is pale, cool, and moist. Cap refill remains under 3 seconds with a moderate skin turgor. Due to the patient's history of melena stool, I will initiate 2 large bore IVs to start a 500 cc bolus and to anticipate a blood transfusion. The patient will be applied to the cardiac monitor to monitor for any further arrhythmias due to poor oxygenation from his bleed. In the same sense, a 12-lead ECG will be ordered to assess for any other underlying issues. Using the acronym AVPU, the patient was A, alert, as he was easily conversing with me during my assessment. As this patient did not have a history of diabetes or an altered level of consciousness, a dextrose was deferred at this point during my assessment. This individual was quite unstable, therefore the doctor was notified of his presence. The patient did not complain of any pain, therefore no analgesia was required. With the information that you have now, what would you designate this patient's level of urgency as well as his CTAS level? As per BCIT 2016, one who is unstable is one with abnormal clinical findings and a history that is considered life or limb threatening. Although this individual did have somewhat normal clinical findings, such as his blood pressure and heart rate, it was his history that was quite insidious. In accordance with the Canadian Triage Acuity Scale, one who has a GI bleed showing signs of marine stool, dark blood, or red blood stool are designated as a CTAS-2 as they are not hemodynamically stable. Doing a quick expose, a quick look is done on the patient, assessing for any deformities, masses, lacerations, or active bleeding. None of these are noted. I am then able to move on to F. Patient's full set of vitals are done, showing a heart rate of 98, blood pressure of 98/61, respiratory rate of 20, SpO2 of 98% on room air, and a temperature of 36.5 orally. For the past 4 days, the patient has been suffering from black stool around 3 times per day. In the same time frame, the patient has been feeling constantly dizzy, nauseated, and generally unwell. Patient has only vomited 1 time, and this was en route to the hospital. No blood noted in emesis. The patient wasn't quite concerned with his black stool. It was the fact that his doctor called him this morning telling him his INR was high. That brought him to the hospital. The patient has a history of heart disease, atrial fibrillation, mantle cell lymphoma, last treated with chemo 3 months ago, GERD, as well as an atrial valve replacement done 10 years ago. Patient is taking digoxin 0.125 milligrams once daily, warfarin 1 to 2 milligrams based on INR daily, propranolol 120 milligrams BID, metoprolol 75 milligrams BID, Lasix 40 milligrams once daily, amiodarone 200 milligrams once daily, rosuvastatin 10 milligrams once daily, and spironolactone 12.5 milligrams once daily. Patient has no known food allergies or drug allergies. Patient denies any alcohol use, smoking, or recreational drug use. Patient lives at home with his wife and says he feels safe in this environment. Pupils equal and round, reactive to light and accommodating. Facial symmetry noted. Air entry decreased to left lobe. S1 and S2 noted upon auscultation. No murmurs noted. Bowel sounds ×4. Abdomen soft, flat, and non-tender. No pain or crepitus to hips upon palpation. Patient moving limbs spontaneously with equal and bilateral strength to all 4 extremities. Pedal pulses palpable.